This video was created by Danny Kessler, associate professor and Korea's first PhD in wellness tourism. The year is 1954. Clinical medicine across the globe is strictly reactive, treating pathology only after symptoms devastate the body. But in Tokyo, a profound ontological shift is born. Clinicians introduce a detailed physical examination involving short-term hospitalization for asymptomatic individuals. They call it the Ningen dock, or human dry dock. Shifting clinical focus from crisis response to asymptomatic auditing redefined the boundaries of healthcare. The name is an explicit maritime metaphor. Just as seafaring vessels routinely return to a dry dock for structural overhaul, mechanical cleaning, and preventative reinforcement, human bodies require a systemic audit. This audit identifies subclinical deviations, catching them before they consolidate into chronic disease. In its earliest iterations at the National Tokyo Daiichi Hospital, this was an intensive, multi-day inpatient evaluation. Patients checked into dedicated hospital wards for several days to complete the protocol. These early protocols pioneered the systematic pairing of blood chemistry with radiology, gastrointestinal fluoroscopy, and early electrocardiogram monitoring. While mapping an asymptomatic baseline was effective at identifying cardiovascular abnormalities and early-stage malignancies, the model required an unsustainable volume of hospital beds per patient. By the 1980s, South Korea was facing a unique challenge driven by hyper-rapid industrialization and a soaring urban population. The country needed to protect its workforce from chronic, non-communicable diseases, but they lacked the resources for multi-day hospital hotel stays. This pressure created a parallel diagnostic phenomenon known as 𝗏𝗏𝗏𝗀𝗏. Medical centers rejected the traditional inpatient blueprint. Instead, they weaponized industrial design principles to build a hyper-efficient, high-volume outpatient engine. South Korea solved their national healthcare bottleneck by applying operational engineering and mass production to clinical diagnostics. This industrial approach reached its peak in 2009 when advanced digital infrastructure was fully integrated into the screening ecosystem. The breakthrough involved marrying the Picture Archiving and Communication System, or PACS, with centralized electronic medical records. This integration automated the clinical workflow, eliminating physical routing delays and moving patient data at the speed of the network. In a modern hub, over 70 distinct diagnostic modalities are executed in a continuous single-direction flow. Digital tracking tags instantly route patients through the clinical hallways to the next available testing bay with absolutely zero friction. This choreography compresses what would normally take weeks of disparate hospital visits into a single, highly coordinated 4-hour window. Maximizing asset utilization and minimizing idle transit time slashed operational costs, democratizing high-end precision medicine at a fraction of the cost seen in Western nations. The impact of these high-throughput environments scales from the individual to the entire population. By gathering millions of data points over decades of routine screening, both the Japanese and South Korean models have built massive, longitudinal epidemiological databases. By analyzing patterns across tens of millions of screenings, these databases act as a predictive shield for society at large. By catching malignancies in treatable stages and shifting the management of cardiovascular health years earlier across the general population, the merger of Japanese philosophy and South Korean engineering has transformed the annual checkup into the ultimate engine for human health span optimization. This video was created by Danny Kessler, associate professor and Korea's first PhD in wellness tourism.